Hey, my name is Nicole Lex. I will be giving this presentation on bipolar in the pediatric population. Let's dive in. All right, the cause to bipolar is unknown. There's a couple different theories, though. There might be a link to underdeveloped structures in the brain. There's a possible genetic link. There is no predisposition for certain ethnicities, race, or gender. And then there's this kind of loose connection with children who are diagnosed with ADHD, who then are later diagnosed with bipolar. However, that might just be earlier signs of bipolar, so that one's kind of unknown. All right, so bipolar, the common onset is between 15 and 19 years old. The most common chief complaint is depression. The difference between adults and children, where we think of bipolar being the manic phase and then the depressive phase, they cycle through them. Each phase lasts about 7 days for adults and then return to baseline and then on to the next phase. Well, for children, it's like this rapid cycle where there is no return to baseline and then they go right into the next phase. So that is the difference between childhood bipolar. And then there is comorbidities with anxiety disorders with or without panic attacks, other disruptive behavior disorders, and substance abuse. All right, so you have a patient coming in who's had depressive thoughts for the last couple months. Your biggest assessment piece will be the psych assessment. So you're going to ask previous psych history, family psych history, and then you're going to be, as they're talking, just assessing for their appearance and behavior, mood, affect, speech, thought process. So if they're having depressive, if they appear to be depressive, they're going to talk slower, they're going to look down, not make eye contact with you, they're going to be tearful maybe, and then have negative themes about themselves or their relationships or world. Or on the other side of things, they might be talking really fast, have a flight of ideas, being super overconfident with themselves, maybe have signs of physical signs of reckless behavior, like they broke their arm because they were trying to climb a tree. And then you're going to be looking at thought content, which would be assessing for like the Columbia Screen for Suicide. So the AAP recommends for the pediatric population between 8 and 11 years old to screen for suicide if it's clinically relevant, which it would be for this situation, and then universal screening after 12. So you'd want to do that. And then also intellectual functioning too. So what their insight is, if their judgment is intact for their specific developmental milestones. But then you also want to look at other differentials too that might mimic some of the bipolar symptoms, such as ingestion of caffeine, taking albuterol or other steroids, or if they already have a psych diagnosis of anxiety with or without panic attacks. Here are 2 acronyms for both the manic and the depressive phases to look for. Your news questions are so important here. And just to touch on a couple of them, looking at their 24-hour intake shows you whether they're having an increase or decrease in appetite. Are they missing school, or how are they doing in school? If they're either depressed or manic, they could be doing really poorly. What are their hobbies? Do they usually like soccer, but they're not doing it? Or are they doing something that's really reckless? And then asking the sleep questions can also kind of dive into whether they're sleeping too much or not sleeping at all. It is really going to be important for us to refer these patients to a child behavioral health provider. They are specialists in this area, and it is really important to put those referrals in. Pharmacologically, it is recommended to start a mood stabilizer. You can do a combination with an anti-seizure and atypical antipsychotic, but antidepressants and stimulants are not indicated, and they can actually trigger a manic episode. Non-pharmacological recommendations are also listed there for you. All right, the prognosis of bipolar in children. If they have a good response to treatment and are adherent, they have a really good prognosis. However, we know with all children and adolescents, they are notoriously bad at staying on regimen with drugs. So for those type of adolescents, it's not as great. And the highest risk for suicide is actually patients that are diagnosed with bipolar. Hope you learned something from this presentation.